Okay, bit of a technical glitch. We'll continue. Fine. We were talking about typhoid. Fine. When we say enteric fever, it includes both typhoid and paratyphoid. And basically, paratyphoid is something that's similar but in a milder form than the Salmonella typhi. So, the antigenic versions and the structure would be discussed more in microbiology. But for our discussion, what is very important to know is the three antigens. Okay, you're supposed to know the three antigens that are very important in the pathogenesis of Salmonella typhi. One is the flagellar antigen or the H antigen. The other is the somatic O antigen and the VI antigen. Coming to the source of infection, humans are the only source of infection. Humans are the only source of infection. It could be the cases or the chronic carriers. Okay, cases or the chronic carriers. Chronic carriers are more important. And cases, they do discharge bacteria from incubation, more so in the 2 to 4 weeks, but it lasts longer than 3 months. But chronic carriers are the ones which are more important. If you see, who is this? Okay, this is Mary Mallon, or a representation of her. We do also call her Typhoid Mary, because why? She was a cook. She was Irish, became a cook in America, and she was the first chronic carrier that was to be ever discussed for typhoid. She infected families and she was forced quarantine to let go. So that is how the term Typhoid Mary came into work. So coming to the roots of infection, the infection is usually foot mouth. So any food or water contaminated with Salmonella typhi, including dairy products, shellfish, flies, cockroaches, all this could cause a Salmonella typhi infection. Finger to mouth contact, and it also includes the feces and the urine. Infected food handlers, they're very, very important, because they're the ones who spread the infection without knowing. And also urine from patients with typhoid or pyelonephritis. These are all the routes through which typhi can be transmitted. Susceptibility and immunity. Acquired immunity plays a very, very important role here. Again, all people are susceptible, but more so the ones who are in contact with the cases and the chronic carriers. But one more thing is reinfection is very rare. That is what we need to remember. And more than anything, immunity, you should know, is not associated with the level of antibodies. Okay, it is not associated with the level of antibodies, and there is no cross immunity between typhi and the paratyphi. Okay, coming to pathogenesis, it's a GI tract host pathogenesis infection, and the amount of bacilli infection to become symptomatic is around 10 to 5 bacteria that should be present. And then these are ingested orally. The stomach or the gastric juice does act as a barrier, where some of these bacilli are eliminated, but the rest enter the small intestine. They penetrate the mucus layer, attaches and invades the small bowel mucosa overlying the Peyer's patches. This is what you need to remember. They invade the small bowel mucosa overlying the Peyer's patches, and then these do engulf the macrophages, mesenteric lymph nodes, and multiplies intracellularly. Okay, and the proliferation of these macrocytes, mononuclear phagocytes, and they spread to blood, and this is the phase of initial bacteremia or the incubation period where the patient is asymptomatic. Okay, next they enter the spleen, liver, bone marrow. These are the organs of the reticuloendothelial system, where the next and they are the proliferation. The actual proliferation occurs here. And then when the bacteria enters blood, that is the phase of secondary bacteremia. And following this, there's a phase of recovery. Okay, again summarizing, so the Salmonella typhi in the gastric juices eliminate a bit of them, and then they enter the intestine, and they affect the mucosa over the Peyer's patches and the lymph node, and that's the phase of the incubation period. Then they proliferate in the mononuclear phagocytes, causing the second bacteremia in the other organs, and then there is discharge into the blood, and then gallbladder and the feces too. Okay, there's hyperplasia of the lymph nodes always swell and they undergo necrosis. Okay, and the complications could be in hemorrhage, intestinal perforation. We will come to that. Okay, again, this is another pictorial representation. You need to remember this. Typhoid is a very important question which is asked. Pathogenesis of Salmonella, you need to remember. This is more or less the same thing that we explained. The incubation period where there's proliferation, and then the reticuloendothelial organs that are affected, and then in the vestigial stage where you see ulceration in the mucosa of the intestine near the Peyer's patches. Coming to what is more important to us in pathology. So what is the lesion that you see is the degeneration of the brush border epithelium. So we have two important things. You need to remember two very important terminologies here. One is the typhoid nodule. This is the essential lesion. That is what we definitely see. Hypertrophied Peyer's patches, proliferation of the reticuloendothelial system. They cause specific changes in lymphoid tissues and the mesenteric lymph nodes. So these are the typhoid nodules that we talk of. And then we have others, the most characteristic lesion, necrosis of mucosa and ulcers in the regions of the Peyer's patches. And unlike tuberculosis, okay, this is very important, pay attention. Unlike tuberculosis, here the ulcers are oriented along the long axis of the intestine. They are along the long axis of the intestine. In tuberculosis, there are transverse. Okay, that's why they are causing strictures. Here, the ulcers are along the long axis. That's why they are not causing stricture of the lumen. In fact, these perforate, mainly bleed and perforate. Typhoid ulcers, that is the reason they bleed and they perforate most commonly. Okay, ileum and the colon. Mostly it is the ileum, that is the region over the Peyer's patches, which is primarily affected. Okay, transmural inflammation, that is involving all the layers, focal necrosis and fibrinous exudate on the serosal surface. These are the things that you will notice. Mononuclear inflammatory cells are the macrophages which have engulfed the bacteria and RBCs. This is what we call as erythrophagocytosis, the nuclear debris, the lymphocytes, plasma cells. And more importantly here again you see neutrophils near the ulcer surface. Okay. This is the area. This is how you see grossly. You see the mucosa which is ulcerated, and more importantly notice that they are along the long axis, unlike the picture that you saw in tuberculosis where you saw they were transverse or perpendicular to the long axis and hence causing strictures and along the lumen. Again, this is along the long axis, and those are the areas where the Peyer's patches are loaded. That is the area of the mucosa below which you see the Peyer's patches. Coming to the microscopy, I told you there is transmural inflammation. This is a whole slide mount to show you all the layers, and you see all the layers are involved. There is inflammation in all the layers of the small intestine or the colon. And what is the cells? These are mostly the mononuclear inflammatory cells or the chronic inflammatory cells, the lymphoplasmacytes that are there. But in the area of ulcer, you do see a predominance of neutrophils too. Okay, coming to typhoid nodules. So whenever there is systemic dissemination, you do see the liver, bone, lymph nodes. So you do see the typhoid nodules. And in spleen, annular, soft, bulging, pale red pulp, prominent cysticytes and reticuloendothelial cells population. So when we say typhoid cells, what are we called? What are these cells? What cells are called as typhoid cells? When we see aggregations of macrophages in a slide. Okay, when you see macrophages within the tissue, and these macrophages you see containing ingested bacteria, RBCs, and degenerated lymphocytes. These macrophages are called as typhoid cells. Okay, you can see it in any of the organs, even in the intestine. Okay, so you will see ingested bacteria, RBCs, and degenerated lymphocytes. Okay, these are the cells, these are the macrophages. If you can see, you see ingested RBCs. These are the huge ones. And coming to the pathology of ileum in typhoid, it is a progressive lesion. So in the first week or during those incubation period, what you see is swelling of the lymphoid tissue and proliferation of macrophages. And the necrosis and the follicles formation starts in the second week, where we call that as a stage of necrosis. The ulcers usually start by the third week. Once the shedding of the necrosed tissue that forms the ulcer, and it is at this stage where it is more prone to bleeding and perforation. And from the fourth week onwards, it goes to the stage of healing, where there's healing of the ulcers. And very important, remember, I'm repeating it again and again. So here there is no contraction like in tuberculosis. Sure. So first week hyperplasia stage, second is necrosis, third is ulceration, and then you have the stage of healing. Okay. Again, after that, clinically, but you have different stages. You have the incubation stage, which lasts for 2 weeks, where the patient is clinically asymptomatic, but the pathological stage and the clinical stage, they usually don't. Here already we have the bacilli which are proliferating, and the mononuclear phagocytic cells are already there, the typhoid cells, and that's why the patient is already infective even though they are clinically asymptomatic. Okay, then after the first week, the bacteremia starts, where the patient starts having temperature, malaise, arthralgia, abdominal pain. Okay, and this is the time where you see the bacilli appearing in the stool. Okay, you will read a lot of about the diagnosis too, I'm talking about the serological diagnosis in microbiology, but what I want you to understand is the stage of when the Vidal test, where the serology, the Vidal test, it starts, but it will start giving a more accurate result or more this thing in the second week. The first thing, or what we see first, is the blood. Okay, we see the blood cultures are the ones which would help initially. Later, it would be the Vidal and then the stool cultures. Okay, so again, lysis in the first week, and then convalescence comes after 4 weeks of symptomatic disease. What are the laboratory findings other than this? We have the WBCs, which can be normal, and more importantly, it is decreased. Okay, there could be decreased WBCs, and especially there could be neutropenia and also eosinophilic leukocytopenia. Okay, more important, forgive me for the mistake here, it is more importantly neutrophilic leukocytopenia. You see neutropenia especially in um, typhoid. Okay, and there's a decrease with the relapse. Again, I told you antibody reaction appears during the first week, but blood cultures are the one which is of most commonly used in the first 2 weeks of illness, and later the urine and stool cultures help. Coming to complications, there is hemorrhage and perforation. These are the two very important complications that you need to remember. Other than that, since there is systemic dissemination, there could also be toxic hepatitis, myocarditis, bronchitis, toxic encephalopathy, hemolytic uremic syndrome, cholecystitis, meningitis, nephritis. And remember, even they can lodge in the gallbladder. So even patients with biliary cirrhosis, they can also be transmitting the disease. So even bile is an important media for typhi. Okay. Next, prognosis. Yes, it is not very fatal. The case fatality is around 1%, but it's high in the immunocompromised, like any other immunocompromised other than old aged and infants. But the carrier rate is pretty high, around 3%. Treatment, isolation, rest, and antibiotics is what works. Coming to paratyphoid fevers, again, they clinically are very similar to typhoid, but a milder form of that. Okay, and to know academic pathology or this thing, they are called by Salmonella paratyphi, and they have three A, B, and C. Okay, so clinically, I told you they are just the same. And if I have to talk about the biopsy, again, the manifestations are the same. It is only the presentation that matters. Okay, in paratyphy A and B, the incubation period is around 2 to 15 days, but the complications and the severity of the clinical symptoms is mild. Okay, and complications are fewer. But the only thing you have to remember is relapses are more common in paratyphy A. And in C, there is a sudden onset, rapid rise of temperature, and they've come as septicemia, gastroenteritis, and enteric fever. Okay, that is about typhi. I want you to remember Salmonella typhi is a causative organism. Cases and chronic carriers are the most important routes. And when we come to morphology, in a biopsy, transmural inflammation of chronic inflammatory cells, the typhoid cells, and more importantly, remember these are the ulcerative lesions, and they are ulcers that are oriented along the long axis, unlike tuberculosis, which is transverse ulcers. Okay, fine. Next, we'll move on to the next infective enterocolitis, that is amoebiasis. And amoebiasis, as we know, is called by a protozoa, Entamoeba histolytica, and this is more common in people and mostly in tropical areas where there are poor sanitary conditions. Okay, again, I will not be going into the details of the structure and the forms. You will be doing it more in microbiology. I'll be just refining and confining to what is needed for our discussion. Okay. There are three stages in amoebiasis. The trophozoite phase. This is what we need to remember because this is what we are going to identify on a H&D section. Then we do also have the pre-cyst and the cyst phages. But it is a cyst phages which is the very infective form. And this is spherical with thick chitinous wall and 4 nucleoli. Okay. And which are the sources of infection? It could be an asymptomatic carrier or a chronic patient who is passing cysts. Okay. And the transmission again is fecal-oral, food and water contaminated with cysts. In amoebiasis, remember 6 F's. Okay, 6 F's in amoebiasis: feces, fingers, fomites, food, fluids, flies. Okay, this will kind of tell you all the etiopathogenesis. Coming to the pathogenesis, the cysts are the ones which are ingested. These are resistant to gastric acid digestion. So unlike typhi, there's nothing that is affecting them in the gastric in the stomach. Okay, the gastric acid can do nothing about it. So these cysts are passed on to the small intestine, and mostly they are in the lower ileum. There is excitation, and the amoeboid forms are released from here. And these amoeboid forms of the trophozoites form invade the mucosa of the crypt epithelium, and that is where the ulcers are seen. Again, this is another condition where we see ulcers in the intestine. So one other differential diagnosis for ulcerative ulcers in the intestine. So excitation occurs here and cysts are excreted in the feces. Again, that gets into the cycle. Okay, this is a pictorial representation. Okay, this is hatch in the small intestine. They release the amoebae and they divide into trophozoites. Again, the trophozoites invade the other parts of the body and reproduce by, or they are excreted in the feces and they accidentally, the humans swallow the cysts. Okay, so it could be self-limiting or an asymptomatic infection in 90% of the cases, but it could be invasive and cause extraintestinal disease in around 10% and 1% of the cases. Clinical features, asymptomatic cyst passage is there, but most commonly they present with dysentery. What do we mean by dysentery? The dysentery is a term to mean diarrhea with abdominal cramps, tenesmus, and passage of mucus in the stool. There are two types, which is the bacterial and the amoebic dysentery. We'll come back to the differences with it. Okay, and more important is it could be fulminant colitis with perforation or a megacolon. Peritonitis is another life-threatening complication that can happen with amoebiasis. Amoeboma, ulceration, and abscess in the liver, lung, brain, emphysema, all these could be presentation of amoebiasis. And then there are four different situations in intestinal amoebiasis which can come. It could be asymptomatic carriers where you biopsy for something and find these are amoeba. Maybe colitis, there could be fulminant or septicemic colitis or an amoeboma. Okay, dysentery, I already told you. This is a term that we use for diarrhea with abdominal cramps, tenesmus, and passage of mucus. It could be with or without blood. Okay, and that is acute. Chronic amoebiasis can lead to extensive intestinal ulcers. Here, there could be scarring or strictures. There could be adhesions. Okay. Coming to amoeboma, what do we mean? What do you mean? I told you there's another situation that you can see in intestinal amoebiasis. So what do I mean when I say amoeboma, or also what is called as Amig Granuloma? This is a very rare complication that happens in response to infective amoeba. There is annular colonic granulation tissue. What is a granulation tissue? So by definition, what you've read in general pathology or till now, granulation tissue is comprising wherever there's an ulcer or a lesion, you have budding capillaries or along with acute inflammatory cells and fibroblasts. So it is something that is granulating. So this results in a large local lesion of the bowel. These colonic granulation tissue, it results in a large local lesion in the bowel and most commonly in the right lower quadrant and presents as a right lower quadrant mass. So this can be mistaken for carcinoma, TB, Crohn's, actinomycosis or lymphoma. That is another reason why it is very, very important. It can be clinically confused for other conditions. Okay, another, like I told you, this is so every lesion has a characteristic ulcer. So we saw the transverse ulcers of tuberculosis and the longitudinal ulcers and typhoid. Amoeba again has its own signature. Okay, here they are flower-shaped or water bottle ulcers. They have a broad base and a narrow neck. Okay, we'll see why it is. And most commonly, amoebic ulcers we see in the cecum, sigmoid colon, ascending colon, rectum, and the appendix. These are discrete ulcers which with normal mucosa in between. If you can see this, these are ulcers. You can see some granulation tissue around, and this is the normal mucosa in between. So they are discrete ulcers with normal mucosa in between. Yes. So when you take a biopsy, this is what you see. This is the narrow neck of the ulcer. This is the flask shape. Can you make out? This is the flask shaped ulcers of intestinal amoebiasis. And why is this so? Because the muscular layer, so this invades the mucosa and spread horizontally along the submucosa. The muscularis mucosa of the intestine is resistant to invasion by amoeba. So it doesn't go down, it goes horizontally into the submucosa, giving this typical flower-shaped ulcer of amoebiasis. So when you see a flower-shaped ulcer, it's amoeba. Okay. Fine. Here you see with the 4 nucleoli, the macrophages that are ingested, and this is how the flower shape. This is discrete ulcers with normal mucosa in between. You can make out these are the discrete ulcers. This is a very high power. So this is a discrete ulcer. It's looking very big with normal mucosa in between. And this is the flower-shaped ulcer. You can see this is a narrow neck and this is extending horizontally. This whole thing is the ulcer. And these are the trophozoites amoebae that we recognize. Okay, they have abundant cytoplasm with a basophilic nucleoli. So these are the organisms. This is the trophozoites of amoebae, which we recognize on the section. Okay, is that clear? Fine. Coming to extraintestinal amoebiasis, the specimens you can take it from, I told you it could have a systemic spread, and more importantly it could form abscess, amoebic abscess in the liver, lung, brain, okay, most commonly other than intestine. And when you take a touch preparation and stain it with Giemsa stain, you can see the trophozoites even in the extraintestinal lesions. So amoebic liver abscess, the trophozoites, how do they reach there? They go via the portal veins, and also they multiply within the liver cells, causing cytolysis of the hepatocytes, and they do accumulate. More importantly, what they're doing is they cause obstruction to hepatic circulation, causing thrombosis of portal venules, okay, and causing liver cell necrosis and abscess formation. It is again life-threatening infection when it ruptures. These abscesses are single, but they are huge. They can measure up to 15 centimeter in the right lobe of the liver, and they are round, circumscribed, solid area of necrotic material with focal softening. You need to remember one very important terminology here, the anchovy sauce pus, which is a grayish yellow chocolate colored pus that you see in liver abscess. And the wall of this is ragged, and they demonstrate the trophozoites of amoeba. So like in any other abscess, there's a incubation period of 1 to 4 weeks. These are the abscesses that I are seeing in the liver, solitary but huge. Okay, how do you diagnose? By stool microscopy. You can use the formalin ether concentration method, or you can do immunoassays. That is what you do, antigen detected in the series. But what is most diagnostic? The diagnostic is a rectal or a colonic biopsy, where you diagnose the flower-shaped ulcer and the amoeba, trophozoites of amoeba. Okay, this is the tissue showing amoeba, trophozoites of amoeba. It is a basophilic nucleoli. And metronidazole and tinidazole are used to treat amoebiasis. Prevention, I mean, you can kill the cysts by boiling. These are the ones which are the transmitting forms, and improve sanitization in the area. Okay, food safety is another important way to, in fact, not just amoeba, to treat all these infective enterocolitis. And again, personal hygiene, very, very important. Now we know in all infections, not just the intestinal enterocolitis, but in all infections, including the present coronavirus. Okay, this is another important table that you need to know. I told you dysentery is a term used to mean diarrhea with abdominal cramps, tenesmus, and passage of mucus. And in dysenteries, we have two types. One is bacillary dysentery and amoebic dysentery. Bacillary dysentery is usually caused by Shigella species, Shigella dysenteriae, Shigella soniae, Shigella flexneri, and amoebic dysentery is caused by Entamoeba histolytica, what we already spoke. So how do we differentiate between these two? In bacillary dysentery, it's an acute onset dysentery, and amoebic is gradual onset. And bacillary dysentery is pure hygiene conditions, poor general condition of the patient. Okay, and bacillary dysentery are comparatively present with high fever, but amoebic dysentery is a mild fever. Tenesmus is severe here and moderate in amoebic. Dehydration is very frequent in bacillary dysentery. How do you diagnose? You look for the trophozoites. Trophozoites are present in amoebic dysentery, and coproculture is positive in bacillary dysentery. Okay, moving on from infective enterocolitis, we will have a brief discussion of malabsorption syndrome. That is again another important topic that you need to know. You need to know what are the types and what is the morphology. That is what we'll discuss here. Okay, So malabsorption, when we say malabsorption, when there's impaired intestinal absorption of nutrients, especially of fat, the most commonly it's fat, but also proteins, carbohydrates, vitamin, minerals also are included. Again, we have two types, primary and secondary. Primary is when there's a deficiency in the absorptive mucosal surface itself or the associated enzymes. Secondary is when there's another lesion in the intestine, which in turn leads to the malabsorption, like any other, like we saw a lot of infective enterocolitis, a congenital or trauma, drug induced. So all these constitute secondary malabsorption syndrome. Primary malabsorption, celiac flu, collagenous, tropical whipples, and gastroenteritis, while in secondary you have mucosal damage with TB, Crohn's, lymphoma, amyloid, radiation injury, systemic sclerosis, or if there is a resection of the bowel, or any drugs. Most commonly, the drugs that are implicated are methotrexate, neomycin, and phenedione. Or there could be impaired absorption because of a short and stagnant bowel or infectious enteritis or parasites. Not just amoeba, it could be giardia, strongyloids, hookworm. Or if there's impaired transport, there could be lymphatic obstruction or AB beta lipoproteinemia. Okay, what is common to all these is in any malabsorption, you have mostly steatorrhea because it's mostly the malabsorption of fat. Chronic diarrhea, flatulence, weight loss, anorexia, muscle wasting are all another important clinical features here. And when we take a mucosal biopsy, generally, what are we supposed to see in a normal mucus? You are supposed to see finger-shaped or leaf-shaped villi in the intestine, in the small intestine especially. But here, there is flattening of these villi. The lining is same, the tall columnar absorptive epithelium with scattered lymphocytes in the lamina propria, but in malabsorption, there is villus atrophy to different degrees. The two different degrees or the two different types that we talk of is the partial or total or subtotal type. In partial, it's a very mild form. The malabsorption could be mild, but still it's present. Here the villi fuse to each other and become, they are short and broad villi, not the leaf-like or the tall, slender finger-like villi. Okay, here the epithelial cells, they show compensatory hyperplasia, and the lamina propria shows increased cellular infiltrate, predominantly of the chronic cells like lymphocytes and plasma cells. But in total or subtotal, this is flattened completely. It's a more advanced villus fusion. Epithelium here is cuboidal. Again, the lamina propria is showing a lot of infiltrate. So this is how you see it, the first normal villi. This is how you are supposed to see a slender, thin, finger-like villi. In partial atrophy, you see they are shorter and they are broader because of the fusion of the villi. But in subtotal or total, the whole villi architecture is gone because they have fused into a lot of degree. And in all of them, you are seeing increased plasma cells in the lamina propria of the mucosa. This is the picture. So here you see this is a short broad villi, but here it is totally flattened off in the cells, but you see dense lymphocytic or the plasmacytic infiltrate in the lamina propria. Okay, so that is about the non-neoplastic lesions. We will list some of, in small intestine there could be a number of tumors. Okay, these are all the tumors that are will be listed, but the morphology of these tumors are same like elsewhere in the body. Okay, the adenocarcinomas, leiomyomas, because the smooth muscle we have already discussed in other adenomas and adenocarcinomas. We'll discuss it in the next class along with the large intestine tumors. Vascular tumors, hemangioma, lymphangiomas can occur in the small intestine, but the morphology of them again is the same like how we see in the how we see elsewhere in the body. Okay, so what we'll discuss today, which is exclusive, is the carcinoid tumors. Okay, we'll discuss carcinoid tumors. Okay, carcinoid tumors are also called as argentifinomas. These are tumors that okay, what's happening? Yeah. Yeah, I can see it. Tumors originating from the endocrine cells. These are also called as Argentine cells or Kulchitsky cells or enterochromatin cells, and they belong to the APUD or the amine precursor uptake deaminase cell system. They are also referred to as APUDomas. Okay, and what is important about these cells is these cells have secretory granules and which stain positively with silver salts. Okay, that is what is unique about them. Okay, coming to carcinoids, you can have, I mean, they are again classified based on the location into foregut carcinoid, midgut, and hindgut carcinoids, of which midgut carcinoids are the most important, which are seen in the terminal ileum and the appendix. Morphology, these are very small, tiny button-like elevations in the submucosa with intact or ulcerated mucosa. Again, you could use this also as DD in ulcerated lesions of the intestine. And when you see this, these are very, very tiny button-like elevations or ulcerated mucosa. And more important, appendiceal carcinoids are commonly involved in the tip of the organs. Grossly, what is striking about them is their color. It is bright yellow on cut section. But on histology, you see solid sheets and nests and cords or clusters of small monotonous uniform cells. Monotonous uniform cells with very poorly-defined cell nuclei. Okay, these are small monotonous cells. You see the nuclei, they don't have very well developed borders. Okay, and regular round nuclei with the salt and pepper chromatin. Okay, so that is about the tumors. And when we talk about the lesions of the appendix, we have covered most of it, but one more important thing that you will read this in uh, practicals too, but you need to know the important lesion in the appendix other than the carcinoid and the tumors we'll discuss together in the next class is appendicitis. Okay, so appendicitis is of multiple forms. Again, what is important to diagnose is acute appendicitis. Also, you could have a chronic appendicitis or recurrent appendicitis is the terminology that we use in our routine reporting. So when we talk about acute appendicitis, it is the inflammation. It's the most common acute abdominal condition, and most commonly it is because of obstruction of the lumen of various etiological forms that leads to it. And it could be a fecolith, calculi, foreign body tumor, worms, or non-obstructive, it could be hematogenous spread from any generalized infection or inappropriate diet or vascular occlusion. What you need to know morphologically, grossly, you have a slide which will be kept for examination. You also have a specimen, gross specimen, which is there for your examination. So you need to know when you come back to the lab, you can see it again. Okay, so the grossly you see that organ is swollen and the serosa shows hyperemia, and if it is suppurative appendicitis, you see the serosa is coated with exudate. Microscopy, you see all the acute inflammatory features. You see an ulcer, granulation tissue, hyperplastic lymphoid follicles, but the diagnostic thing what you will have to look for or what will be focused in a spotter is the neutrophilic infiltration and transmural infiltration. So you should look for this neutrophilic infiltration not just in the mucosa, submucosa, throughout all the layers, more importantly in the muscularis. Okay, so this is a transmural. You are seeing the mucosa, submucosa, even the muscularis C showing this neutrophilic infiltration. And there is usually ulcer, which is not depicted here. Usually there is ulceration of the mucosa. Okay, this is a pictorial representation. This is the muscularis propria showing neutrophils. Okay, so these are this almost covers all the lesions of the small intestine. We do have what is left in the lesions of the intestine are the polyps and colorectal or the carcinomas. I would club all that into the lesions of the large intestine, and I'll take that in the next class. Okay, so this week you will be having test assignment on renal system. Next week I'll be scheduling one more class that will be the last class of GIT, where I'll be taking all the polyps, a very, very important topic again. And along with that, we will, next week after the last class, I'll be giving you an assignment on GIT. Okay, so that is it. Any doubts? You can let me know if you have any doubts. You can message in the chat later or two. Okay. Okay, if there are no doubts, thank you so much. And we'll have one more class on GIT and the assignment on next Sunday, not this Saturday. The next Saturday, we'll have an assignment on GIT. Okay, thank you.